Hello, this is mental health consultant Jason. The purpose of this training is to give you a more thorough understanding of clinical depression. We will begin by exploring issues regarding the diagnosis of depression. We will then turn to the causes and effects of depression and end with the treatment of depression. This training is based off of a review of the most relevant research on the topic to date. Depression affects an estimated 121 million people worldwide. It plays a significant part in the estimated 850,000 suicides worldwide each year. One study compared social conditions with depression in 18 countries across the world through interviews with 89,000 people and found that 15% of the population from high-income countries were likely to get depression over their lifetime, with 5.5% having had depression in the last year. Some aspects were cross-cultural. Women were twice as likely to suffer depression as men, and the loss of a partner, whether from death, divorce, or separation, was a main contributing factor. Mental disorders are the leading cause of years lived with disability worldwide, with 40.5% of this burden attributable to major depression. Prevalence rates of major depressive disorder increase dramatically across adolescence, and females have 2 to 3-fold greater rates than males. One study that analyzed data from 6.9 million Americans shows that people now report more psychosomatic symptoms of depression, such as trouble sleeping and trouble concentrating, than their counterparts in the 1980s. Adults were more likely to experience symptoms such as restless sleep, reduced appetite, and feeling fatigued. Interestingly, people are not any more likely to say that they are depressed when asked directly, suggesting that the rise in symptoms is not based on people being more willing to admit depression. Also, the use of antidepressant medications doubled over the time period between the 1980s and now. Now that we have some understanding of the impact of depression, let's discuss its diagnosis. The DSM-5 lists multiple depressive disorders with specific criteria and specifiers. We will briefly review only the general criteria for major depressive disorder in this training for the sake of brevity and because it is the most stark example of depression in action. In order to be diagnosed with a major depressive disorder, an individual must have experienced the following criteria for a minimum of 2 weeks. They must have at least 5 of the following 9 symptoms, and at least one of these symptoms must be depressed mood or anhedonia. Other symptoms may include significant weight changes or loss or increase in appetite and insomnia or hypersomnia most days. Also, those experiencing a major depressive episode may have observable psychomotor agitation or retardation nearly every day, fatigue or loss of energy nearly every day, feelings of worthlessness or excessive or inappropriate guilt nearly every day, diminished ability to think or concentrate, or indecisiveness nearly every day, and recurrent thoughts of death, not just fear of dying, recurrent suicidal ideation without a specific plan, or a suicide attempt, or a specific plan for committing suicide. It is important to note that the criteria specifically state that most of these symptoms occur for the majority of the day, nearly every day. In addition to the previous criteria, the depressive symptoms must cause clinically significant distress or impairment in social, occupational, or other important areas of functioning, and cannot be due to the direct physiological effects of a substance or a general medical condition. As a result, diagnosis of clients entering the jail system that have significant chronic illnesses or may be on or recently have taken substantial amounts of mind-altering substances will be difficult to adequately differentiate as having a true clinical major depressive episode. A serious issue with the diagnostic criteria of depression is that these same symptoms can also occur in normal responses to loss and stress. This can result in possible false positive results when someone is diagnosed with depression when they are in reality acting normally with intense sadness to life's stressors. Research has estimated that approximately 25 to 33% of diagnoses of major depression due to community surveys are in fact false positives. Diagnostic issues in psychology present philosophical and semantic challenges. Diagnosis of many psychiatric disorders, including depression, is more of a symptom analysis rather than a concrete diagnosis of an absolutely verifiable disorder. The presence of cancer, for example, is often indisputable given specific physical tissue markers, whereas the verification of depression due to DSM criteria is determined by symptom assessment, not objective biomarkers. However, with the advent of new technologies and testing, the objective determination of depression is beginning to become a reality. We will explore this issue further in the training. The American Psychiatric Association is aware of the problem of symptom analysis being equated with diagnosis and attempted to rectify the problem by including a clinical significance criterion in the DSM-4. The clinical significance criterion states that people with depression must experience symptoms for a minimum of 2 weeks, and that the symptoms must cause clinically significant distress. These criteria were added to reduce false positives regarding depression diagnosis. Unfortunately, a recent study shows that the clinical significance criterion are ineffective at reducing false positives, thus giving further support to the fact that diagnosis of mental health disorders is highly subjective. Even the much touted cognitive behavioral therapeutic techniques that are the current treatment du jour due to their evidence-based label are primarily based on subjective indices and interpretations of clients and clinicians, not on objective criteria. As evidence, consider the PHQ-9, which is a Likert scaling of subjectively assessed depression symptomatology. Even most CBT and DBT homework assignments are almost entirely dependent upon the ability of the client to record accurately their behaviors, which are objective, and cognitions and affect, which are inherently subjective. Clinicians should be cautious to not fall into the trap of believing that there is more objectivity in mental health diagnosis than there really is, and thereby encourage clients to think in a similar manner, which can increase a sense of determinism, if not fatalism, and can contribute to social stigmatization. Research has also shown that some symptoms play a much bigger role than others in driving depression, and that the symptoms listed in the DSM may not be the most useful ones. Researchers analyzed data on 28 symptoms provided by over 3,000 depressed patients. They then examined the connections between these symptoms. Their network analysis shows that some symptoms are more central, more connected than others. As a result, these symptoms have a much bigger impact on the depressive process. Depression thus appears to be a network of interacting symptoms where one symptom can exacerbate or cause another. The researchers concluded that the symptoms featured in the DSM-5 are no more appropriate as indicators of depression than non-DSM symptoms. The most central non-DSM symptom found in the research was sympathetic arousal, palpitations, tremors, blurred vision, and sweating, featuring strong connections with somatic complaints, limb heaviness, pain, headaches, gastrointestinal problems, and panic and phobia. Apart from sympathetic arousal, 2 anxiety symptoms, panic and phobia, and anxiety tension, exhibited high node strength values. A host of studies have documented the important role of anxiety in depressed patients, which predicts reduced treatment efficacy. It is important to reiterate that these symptoms are not DSM criteria. The research results are consistent with a previous study examining the impact of DSM depression symptoms on impairment of psychosocial functioning, in which the 2 DSM core symptoms of depressed mood and anhedonia along with energy loss and concentration problems, were the four most impairing symptoms. The researchers concluded, this network perspective does not support the integrity of the DSM criteria, and the reasons why particular symptoms are featured in the DSM seem to be based more on history than evidence. Another issue related to the subjectivity of depression diagnosis and its potential effect on clients is a study which looked at increased rates of prescribed antidepressants resulting from PHQ-9 screenings. The study had clients initially take the PHQ-9 before seeing a doctor, the results of which the doctor never saw or was made aware of. Clients were then separated into two groups, one of which didn't take a PHQ-9 again, and another which did with their physician present. The study showed that for all clients that scored low on the initial PHQ-9 and therefore did not appear to be depressed, that if they completed another PHQ-9 with their physician, they were 3 times more likely to be prescribed antidepressant medications than those clients that did not complete a PHQ-9 with their physician. Given the known side effects of antidepressant medications, such as sexual dysfunction and weight gain, it brings into question the efficacy of utilizing depression screenings, such as the PHQ-9, on large numbers of clients or those that do not appear to be or are unlikely to be clinically depressed. Other research, which was conducted by the U.S. Preventive Services Task Force, an independent volunteer panel of experts that makes recommendations about the effectiveness of specific preventive care services, such as screenings, counseling services, and preventive medications, reviewed the evidence in the medical literature on the benefits and harms of screening for depression in adult populations, including older adults and pregnant and postpartum women, the accuracy of depression screening instruments, and the benefits and harms of depression treatment in these populations. They recommended that adults 18 and older be screened for depression. They found convincing evidence that screening improves the accurate identification of adult patients with depression in primary care settings, including pregnant and postpartum women, and found adequate evidence that programs combining depression screening with adequate support systems in place improve clinical outcomes, such as reduction or remission of depression symptoms in adults, including pregnant and postpartum women. The optimal timing and interval for screening for depression is not known. They suggest that a pragmatic approach might include screening all adults who have not been screened previously and using clinical judgment in consideration of risk factors, comorbid conditions, and life events to determine if additional screening of high-risk patients is warranted. Positive screening results should lead to additional assessment that considers severity of depression and comorbid psychological problems, alternate diagnoses, and medical conditions. They concluded with at least moderate certainty that there is a moderate net benefit to screening for depression in adults 18 years and older, including older adults, who receive care in clinical practices that have adequate systems in place to ensure accurate diagnosis, effective treatment, and appropriate follow-up after screening. They also concluded with at least moderate certainty that there is a moderate net benefit to screening for depression in pregnant and postpartum women who receive care in clinical practices that have CBT or other evidence-based counseling available after screening. Another study looked at how different races reported depressive symptoms and showed that screening instruments can reliably predict the likelihood of developing major depression at a later date for whites, but not for blacks. This difference persisted even after the researchers corrected for differences in the participants' social, economic, and physical health status. What did seem to predict later depression for blacks was their self-rated health, which was answered by a request to rate their overall health on a scale of excellent to poor. Blacks whose self-reported health status was worse at the start of the longitudinal study were more likely to have major depression later on. Another study has shown that young people who are high on the personality trait of neuroticism are highly likely to develop both anxiety and depression disorders. The researchers encouraged screening for neuroticism to help determine the probability of developing depression and anxiety disorders. Theorists believe that neuroticism makes people more susceptible to negative emotions, such as anxiety, depression, irritability, and anger. Researchers have created a color wheel that can be used to assess for depression in individuals. A study has been done on the color wheel showing that depressed individuals showed a striking preference for negative colors compared to healthy controls. To use the Manchester color wheel, all you need to do is show a client the wheel and ask them which color best represents their current mood. This assessment tool can be especially helpful with clients that have limited language skills, have impaired cognitive functioning, or limited insight into their emotional states. This is the Manchester color wheel. If you show it to a client and ask them to point out or tell you the number corresponding to the color that best represents their current mood, and they pick a color between 33 and 37, it is potentially an indication of a depressed state. The diagnosis of depression is becoming more objective with the use of brain imaging. Brain scans may now be able to identify children who are vulnerable to depression before symptoms appear. Researchers have found distinctive brain differences in children known to be at high risk because of family history of depression. The finding suggests that this type of scan can be used to identify children whose risk was previously unknown, allowing them to undergo treatment before developing depression. Previous imaging studies have revealed two brain regions that often show abnormal activity in depressed patients. However, it was unclear if those differences caused depression or if the brain changed as a result of a depressive episode. To address that issue, the researchers decided to scan brains of children who were not depressed according to their scores on a commonly used diagnostic questionnaire, but had a parent who had suffered from the disorder. Such children are 3 times more likely to become depressed later in life, usually between the ages of 15 and 30. Using functional magnetic resonance imaging, fMRI, the researchers measured synchronization of activity between different brain regions. The researchers identified several distinctive patterns in the at-risk children. The strongest of these links was between a set of brain regions that is most active when the mind is unfocused. This abnormally high synchronization has also been seen in the brains of depressed adults. The researchers also found hyperactive connections between the amygdala, which is important for processing emotion, and which is shown here, and the inferior frontal gyrus, which is involved in language processing, the location of which is shown here. They also found lower than normal connectivity within areas of the frontal and parietal cortex, which are important for thinking and decision making.